Hello everybody, this is Carlos from Army of Nurses and welcome to another video. Today's video we will be covering the topic of arterial lines, and this is meant to be a guide for nursing students so that if you do encounter an arterial line in your practice, you get a better level of comfort and confidence to deal with them. Some of the topics that we will be covering include advantages of having an arterial line and some disadvantages, common sites for insertion, waveforms, assessments, equipment needed, blood sampling, troubleshooting, changing the saline bag and the tubing system, and some indications for the removal of the arterial line. So what is an arterial line? An arterial line is simply a cannula that has been inserted into the arterial part of the circulatory system, because that's the part that's pressurized, so that blood pressure can be monitored very closely. Which brings us to some of the advantages of the arterial line. So more accurate monitoring of blood pressure, systolic, diastolic, and mean arterial pressures. It is used for accurate and close titration of vasoactive medications, so medications that have an effect on your blood pressure and your heart rate. And it is also used for patients who need a very frequent blood sampling, so that you don't need to poke the patient every time you need to do blood. And with advantages as well, it comes disadvantages like everything else. So some of the disadvantages include discomfort to the patients. It can compromise the limbs where it is inserted, because remember, it is inside the artery, so it's occupying some space inside. Therefore, it can compromise the blood flow in that artery and the limbs that it supplies. Bleeding, hematoma, bruising at the site, arterial line malfunctions. That means the patient will not be able to move as much when they have an art line inserted, and it depends on the location. And infection. So some of the common sites for insertion of the arterial line are as follows. The radial part insertion, it's preferred at the radial site because it's easy to access. It provides quite an accurate reading. If there is bleeding, it's actually quite easy to control. Just put pressure on it. And it actually provides the patient with the maximum amount of mobility given the art line in situ. Obviously, some disadvantages is the radial artery. It's quite small in diameter, which might cause it to be difficult to insert, especially if patients are hypotensive, and it can cause nerve damage or thrombosis. B, as you can see in the picture right here, right? That one there is the brachial site, and the brachial has a larger diameter than the radial, and therefore it's a little bit easier to insert, and bleeding is relatively easy to control as well by putting direct pressure. Some of the disadvantages of the brachial means that the limb might need to be immobilized, because it's quite the arterial line becomes quite close to the body, because it's quite up in the arm. There's a higher risk for thrombosis, and there's limited collateral circulation. In the radial, at least, there's the ulnar artery that is providing the collateral circulation. In the brachial, it's a little more limited in that sense. C over here, femoral. That's one of the sites and one of the last resort sites that usually they will go to. The femoral artery has quite a large diameter. It's easy to insert, and it's easy to insert even on patients who are quite hypotensive. So usually it's the last resort, and it does have their disadvantages because the limb needs to be quite immobilized. The patients will have an arterial line coming out from the groin. It is hard to visualize because you want to provide some privacy to the patients. Therefore, you're going to cover them quite up to the groin, or even a little bit more. So it's a little bit hard to visualize compared to radial and brachial, that you can just leave it exposed, right? It's a little bit harder to control bleeding because of the site and because it's a larger artery. So if there is bleeding, the side effects of that or the consequences can be a little bit more catastrophic. And it's more prone to infection because it's very close to the perineal area. Um, Next, we're going to see some of the waveforms or the arterial line. So arterial lines in your monitors will usually be denoted in red color, like you see here. And this is a normal arterial line waveform. So this is the systolic peak. So when the heart contracts, this is the top systolic peak, the dichotic notch, and the diastolic pressure down here. So the dichotic notch happens because when systole ends, there will be blood that will be backtracking into the heart, right? So that heart, the heart will catch um, that blood. It's gonna be catch by the aortic valve, and it's going to have a little bit of a rebound on it. So when the blood falls on it, it's gonna rebound, and that's what's gonna cause the dichotic notch, and then the pressure is gonna further drop. So this is indicated by blood bouncing on the aortic valve before the pressure keeps going down as per diastole. Um, which brings us to the topic of waveform dampening. So it is quite common to see arterial lines being dampened because, if a patient move their arms, which is here positional. It could be up against an artery wall. The cannula inside could be kinked. Patient could be hypotensive. There could be blood clots at the tip of the cannula. And instead of seeing nice spikes with the dichotic notch coming down in here, you're going to see a dampened waveform like that. So when that happens, it's always good to check, right? Always check your patient first. Which brings us to assessment. And in the assessment part, we are going to be covering the Allen's test, zeroing the system and its usefulness for it, checking the pressure for accuracy, and your neurovascular assessments, commonly known as your 5Ps, right? So Allen's test. The Allen's test is used to check for collateral circulation in the arms. So this is the radial part. This is the ulnar part. So how the Allen's test works is by obstructing the radial and the ulnar, you ask the patient to close their fist, and then when they open their fist, you should see the whole hand blanch because you're blocking both supplies of blood, right? Next, what you're gonna do is you're just gonna cover one side. So you're gonna cover the radial and have the patient close their hands again and open it up, and you should see the hand return to pink because the ulnar is unobstructed and it should be supplying the hand with blood. Next, you do the opposite, right? So you obstruct the ulnar and you leave the radial open and do the same thing. Have the patient close their fist and see that their hand goes from white to pink in a relatively short amount of time, right? In a few seconds. That will mean that the patient does have good collateral circulation, and cannulation by insertion of an arterial line is adequate for that patient. Next, we need to zero the system, and the reason being is because the atmosphere, it does have a pressure that exerts on the system, and it can make the readings inaccurate. So by zeroing the system, we're telling the transducer to ignore the pressure from the atmosphere and only concentrate on the pressure from the patient. Zeroing should be done at the beginning of your shift, every 4 hours, every time blood is taken, and as needed. So zeroing the system, it's this part is the one that causes a little bit of confusion for students who are not familiar with arterial lines, or even nurses who are not familiar with arterial lines. So this is your transducer right here. This cord is going to be connected to your monitor. This is where the saline bag is gonna come in, your pressurized saline bag, right? That's where it flush and it's supposed to go in. And this part here goes towards the patient. So there's a stopcock right here. The stopcock, as you can see it over here to the little white thing, the rule of thumb is whichever way this stopcock is pointing to is closing that way. Okay, so we take a look at this part here. The stopcock is actually pointing up, right? So the patient in this way is open and is also open to the back and the transducer. So this system is an open system, is off to the atmosphere, which once your arterial line is working, you want it to be off to the atmosphere like this. This one over here, you can see that it is pointing towards the patient, right? This is the line that would come up from the patient. And this part here is close to the patient. So it's open to the atmosphere and open to the system. So this is what you will do when you zero. When you zero, you close it to the patient because you want to tell the system, hey, ignore the atmosphere. So once the system ignores the atmosphere, the only pressure that the system will have to look at is the patient's pressure. So that's how it works. And if you want to take blood, that's right, you guessed it right. So this little point will be turned all the way towards the transducer, which means that it will leave the patient side open and the atmosphere side open, right? Because the little white thing will be on this side here. So once it's turned all the way to the other side, then that's how you can take blood, right? Remember, whichever way the stopcock points to, is the pathway that is closed. Okay, the other two are open. Like this one, open this way, closed that way. This one, open this way, right? And is closed this way. Next, we gotta make sure we check the arterial line for accuracy. And that's usually done by, you want to make sure you compare it to your non-invasive BP. So your cuff pressure, right? So your cuff pressure and your arterial line pressure, they sometimes might be very close to each other, and sometimes they will not be as close. But the rule of thumb is if the discrepancy is more than 20 millimeters of mercury, then that's considered to be inaccurate between both. Once you check your cuff pressure, then you can have and you match it with your arterial line pressure, then you have a backup system in case your arterial line fails. Because if the arterial line, when it was working and it's quite accurate to the cuff, if it does fail, because it does fail, actually they're not perfect, then you can still use your cuff and you can be assured that that pressure from your cuff is quite accurate, right? Next, our neuro assessment. You know, the 5 Ps. We're gonna check for pain of the extremity where the arterial line is inserted. We're gonna check for pressure, for pulses. We're gonna check for the collateral pulses. Make sure that you know your cap refill. You check on that. Pallor. Make sure that your hand it's nice and pink. There's no discoloration, no cyanosis. Paresthesia, make sure that the patient does still have sensation, it's able to tell you when you touch their fingers, make sure they don't have any numbness or tingling, and then in paresis, make sure that the patient is still able to move, right? So their CSM remains intact. So some of the equipment needed for insertion of an arterial line are as listed in here. Just make sure that you check your policy in your hospitals, because different jurisdictions, they have different rules about who can insert art lines. In some countries in the world, RNs are allowed to insert arterial line, but in Canada, where I'm from, it falls under the scope of practice of the respiratory therapist, and the physicians are the ones that are able to do that. As nurses, we have the role of making sure that the arterial line remains patent, and that the patient is not compromised by the arterial line. So some of the blood sampling, when you do get some blood from the arterial line, which is the amazing stuff, always make sure to waste at least 10 cc's of the initial blood, because that blood there is hemodiluted and is not accurate for test. So once you draw that up, then your next will be to put your tubes without any additive. And the colors of the tubing and the brands will vary very widely, even within hospitals in the same city. So I have to check your policy with that. Next, you're gonna draw blood tubing with additives in it, followed by your anticoagulation profiles, so your PTINR. Usually is the blue top over here with the citrate in the bottom, the little liquid. And last but not least, you're gonna do your ABGs. And it's always just remember to zero your system after you use it. Don't just turn the stopcock back to the atmosphere and let the system run. Make sure you zero the system and flash the tubing to ensure that the art line remains patent for next time you need blood. Some of the troubleshooting things that you will need to know about. So one, if you cannot flash the system, it could be because the stopcock is in the wrong position, or there's not enough pressure in the bag. The tubings might be kinked, or there is some blood clot in the cannula tip. So solution, you're gonna place the stopcock in a correct position. You're going to ensure that the bag has enough pressure, and all those pressure bags have a green indicator that will indicate you when there's enough pressure in the bag. So make sure it falls on the green part. Check your tubing for any kinking, and if you suspect any thrombus in the line, it's always good to notify the doctor. If you cannot obtain pressures reading, it could be because the stopcock again is in the wrong position, or the cables might be disconnected. So solution, check the patient first always, if you cannot obtain a pressure. Ensure that the stopcock is in the correct position, and check the cables for connections. Make sure everything is secure. If there's bleeding at the site, it could be caused by frequent movements of the limb, because remember, it's a foreign object in the arterial part of your vasculature system. So when patients move too much, it rubs against and it causes some kind of irritation on the artery part. So it's more frequent for it to bleed. At least there's a higher chance for it to bleed. So another cause could be the art line could be disconnected from the tubing, and that is quite frequently that could happen, especially when there's a lot of movement around, or if at the beginning the tubing were not secure properly. So your solution obviously will be to immobilize the limb, check your 5Ps from your patient, ensure that the system has the integrity of the whole system has not been compromised, and you're gonna apply direct pressure to the bleeding site until bleeding stops. There's bleeding on there's blood on the tubing. It could be because the system is not properly pressurized, so the system might be disconnected. Again, you're gonna put more pressure into the bag and check the system for any disconnections. Dampening of the pressure readings could be the catheter against the wall, thrombus on the tip of the catheter, loose connections, the patient might be hypotensive. And your solution will be to counter all of those things, right? Check the patient, you're going to reposition the limb. You can use a syringe to try to aspirate any blood. So if you don't get any blood from the art line by aspirating, then it could mean that there is a thrombus on the tip that is blocking the blood flow into the art line. And it's always good to check your calf pressure to ensure that that one, your patient is okay, and two, that to check that your pressure is quite accurate to the art line. So 6, if your readings are too high or too low, maybe because you failed to zero the system, your transducer is too high or too low, or it could be because the catheter is whipping inside the patient's arteries. Check the patient as a solution, ensure the transducer is at the level of the right atrium. and zero the system, as needed and as per your protocol. So changing the saline bag and the tubing system, a lot of places they put saline only on the pressure bag. Some institutions might use heparin, although I haven't seen that being used, at least in where I work. And the bag needs to be changed daily. So when you change the bag, always make sure that you take away all the air, which is something that a lot of people forget. Don't just hang the bag and just start pumping the pressure bag for it. And the reason being is because if your bag runs slow and there's air in it, and because the bag is pressurized, you can push that air into the patient and they can have air embolus, and that's quite dangerous, especially in the arterial side. So always take away all the air using a syringe, and just leave only liquid inside, because every bag will come with a little bit of air inside. And your tubing, it varies. In the hospital I work at, it's changed every 72 hours. In some places change it maybe a little bit later, 96 hours. But if the tubing system is compromised, if there's kink and there's clots, you can change the PRN. Just make sure that when you do it, if you're not comfortable changing the line yourself, to have a colleague by your side, because you need to unscrew the cannula from the tubing and the patient's gonna bleed. And sometimes their pressure can push the cannula out and you will lose your arterial line completely. And the respiratory therapist will not be happy with you. Um, some indications of when to get the arterial line removed. One, you don't need arterial pressure monitoring any longer. If you do have neurovascular compromise, so any of the 5Ps that the patient might complain about. If there's excessive bleeding at the site, the pressure itself cannot control, it's an indication for you to take the arterial line out, because there might be some damage that is causing. Infection and sepsis. Just make sure that if you do take out the arterial line and you need it for culture or sampling, then keep it sterile. If there's a system failure because it's constantly dampened, it's kinked, there's a thrombus on the tip, or if frequent blood sampling is no longer necessary. So removal and post-removal, again, check first that there is a doctor's order to discontinue the arterial line. Or if you're in the ICU or critical care departments, a lot of times you can use judgment. If there's any of the indications for removal, I mean, if the patient's septic and the art line is kinked and stuff, a lot of places, a lot of times like that, nurses are able to take out the arterial line and let the doctor know that with obviously a sound judgment of why it was taken out, right? And 99% of the time the physicians will agree, and that's okay, but always check your doctor's orders first. Check your coagulation studies prior to taking art lines. It's especially true in if your arterial line is in the femoral artery. Because of the bigger artery, there is a higher chance for it to bleed, and if you're anticoagulated, then it's gonna bleed a little more. So a rule of thumb is, a lot of places they keep their anticoagulation medications or the blood thinners 2 hours before the removal of any lines. Ensure that the tip remains sterile, again, in case you need it for culture. Ensure that you apply direct pressure on the site for at least 15 minutes, and you need to count your 15 minutes, because the arterial part of it, sometimes it doesn't stop bleeding. It just keeps coming and coming. So 15 minutes at the very least. Visual check for bleeding, hematomas, and bruising at the site. You have to do that with your assessment. Apply pressure bandage to the site once bleeding has been controlled. And once you apply the pressure dressing on, you still need to check for your 5Ps to ensure the patient it's okay. And that concludes the very short tutorial regarding art lines. I hope that you found this informative. If you like the video, just like and subscribe, and I'll see you next time. Thank you very much.